Good morning and welcome to the EACTS conference in Amsterdam. Welcome to this series of Giants interviews. I'm here with Professor Stephen Westaby. Good morning.
Good morning. Nice to be here.
To talk about his outstanding career and his many, many achievements over the years. I think he needs very little introduction, so I think we'll go straight into the interview.
Thank you. Well,
thank you for joining us.
If there's any point in doing an interview like this, it's to try and help inspire young people. I began with very humble beginnings in the back street of a northern steel town. And I got to the age of 7 in 1955 and saw in a little black and white television set that my parents got for the first time, Your Life in Their Hands. And they were talking about John Gibbon and the heart-lung machine. And Dennis Melrose at the Hammersmith and Hugh Bentall were starting to try to do cardiac surgery. And as a backstreet boy, I was very taken by this. And I said to myself at the age of 7, I'm going to be a heart surgeon. Not a proper doctor. I was single-minded throughout. And up in Scunthorpe, I worked in the steelworks. I worked as a porter in the operating theatres. I used to go to the mortuaries to watch the autopsies. And I eventually got to medical school in 1966 in London at the old Charing Cross Hospital, which was absolutely fabulous, on the Strand, next to the theatres with the Savoy across the road, Covent Garden, and it was wonderful. But the first thing I did was to find out in the medical school, did they do heart surgery? And they used to do heart surgery once a week. And medical students weren't allowed across there, but I found out where it was, and I went up to an old ether dome in the eaves, under the eaves of the old Charing Cross Hospital, dark and dusty place, but I could look down directly over the operating theatre and watch the surgeons trying to do heart surgery. And they were using massive old rotating disc oxygenators, spinning in pools of blood. And I used to sit and watch the whole thing, and every week on a Wednesday, the patient died. And I saw some terrible things in the ether dome because they were trying to treat young people with rheumatic disease, and one after another, they died. I was a waster at medical school. I was captain of cricket, and I was captain of rugby, and I was the social secretary. But being a notable waster, at the end of my medical school career, I got a national scholarship to go to New York, to the Albert Einstein Hospital in New York. And so the boy from the back street set off on an airplane from the first time, touched down in New York City at Kennedy Airport, and went up to the Bronx. And I had a fascinating time there, and guess what I did? Cardiac surgery. And there I started to see people survive cardiac surgery, and I learned a lot about it. And I came back absolutely fixated on being a cardiac surgeon. Now, I then had a lot of luck. I was made the houseman to the famous professor of medicine at Charing Cross, Hugh de Wardner, who began renal dialysis, and then to the professor of surgery, Harding Raines, who always took the rugby captains. And life was like that in those days. And we used to work round the clock. I did the primary fellowship very quickly, failed it first time, got it the second time, went to the Brompton. And when I got to the Brompton, for me this was the epitome. Oswald Tubbs, who began mitral valvotomy, was still there. I worked for Christopher Lincoln, who was beginning pediatric cardiac surgery, and Matt Panath. Matt Panath was a 6'6" German, very intimidating and a very interesting character. And I worked very hard for these guys. I lived in the hospital. I worked day and night as we used to in those days. But unlike today, they used to give us dinner in the boardroom in the evenings with wine. Quite extraordinary. And when I started to go to the operating theatre, I found in a dusty old cupboard Lord Brock's discarded white operating boots. Down the back it said Brock. So I purloined Lord Brock's boots and paraded myself around the operating theatre at the Brompton. Now, I sat in the outpatients one morning with Paneth, and he said, Westaby, it's about time you went and opened a chest. And I'd never done any surgery at that point. I'd not even been a house officer in an A&E department. But me being me, I said, fine, off I go. And I went to the theatre, and the nurses were eager to get started, and the patient was prepared and draped. And I knew it was a little old lady for a mitral valve replacement. What I didn't know was that she'd had a closed mitral valvotomy, and she had adhesions. And they'd opened the pericardium behind the sternum. So the first time I used a sternal saw, it went into the right ventricle. And the nurses panicked a little bit because they knew I was green as grass, and sent for Mr. Paneth. Now, all I could do was to try and stop the bleeding. So I got that sternum open and put my fist in and said, give me a stitch. And I just stitched up the right ventricle. And by the time Paneth appeared at the door of the operating theatre, he walked in wearing his suit. And he said, Westaby, what have you done? And I said, I've had a slight accident with the right ventricle, Mr. Paneth, but it seems to be all right now. So he walked off and had coffee, and I dissolved in a heap of perspiration on the floor, but it was okay. That got me started. I was then very lucky to go to Cambridge for my general surgical training. And I started in Cambridge on the rotation there at Papworth with Terence English, as he was starting to get to grips with cardiac transplantation. So I continued to develop in cardiac surgery, did more and more, and went to Addenbrooke's then with Roy Kahn, who was beginning liver transplantation. And it was a very, very, very exciting time. The thing about Cambridge was that the senior registrars at the time used to do transplantation and were on that rota, and the younger guys like myself did the emergency general surgery. So alternate nights I operated, and I operated, and I operated, and I operated. And I did abdominal aortic aneurysms as a registrar, hemihepatectomies, pan-proctocolectomies. They were prepared to let you do what you could do. And for me, that was a very important thing, because I think beginning cardiac surgery without being an accomplished operator is extremely difficult. Yeah. So that was a very good experience. I got the fellowship of the College of Surgeons the second time. I failed it the first time. The reason I passed the second time was I was still a rugby player, and I fractured my jaw playing rugby one Saturday afternoon. Roy Kahn used to love me to play rugby because I got my name in the newspapers. But having fractured my jaw, I came in and sat in A&E, waiting to be seen by an orthodontic surgeon. And as I sat waiting, they brought in a student that had come off a motorcycle right in front of the hospital gates with a transected aorta. And Papworth was miles away, and there was no one to intervene with a ruptured aorta. So I actually was called through to see if I could do anything in my rugby kit with a fractured jaw, covered in mud, and I did a thoracotomy in that state. And the guy did not survive, I have to say. But as I did that, the orthodontic surgeon arrived and said, "Where's Westaby?" And they said, "He's in the emergency room with the chest open." And the orthodontic surgeon thought it was me. I'd inhaled a tooth, and I'd had a cardiac arrest. And when I saw him, he looked white as a sheet because I was covered in blood and still wearing the rugby gear. So that formative years. After which, I went to the Hammersmith. Having seen the Hammersmith on Your Life in Their Hands, I found myself at the Hammersmith as a registrar with Professor Bentall, Melrose, and the team, and I just took off. And because I could operate again in those days, they would let you operate. So within 9 months, I went from registrar to senior registrar. And I said to Professor Bentall, I need to train in America. Everybody goes to America to train. And I said, I've seen heart transplantation in Cambridge. I want to go to Dr. Shumway in California. And I remember Bentall said to me, Westaby, you're completely undisciplined as you are. If you go to Shumway, you'll end up even worse, a total wreck. You've got to go to Kirkland. If you go to Kirkland in Alabama, we'll take you back with the prospects of being a consultant. So off I went to Alabama, which was one of the best things I ever did. Got into the American culture, doing rounds at 5 a.m., starting to operate at 7, working through in the research lab till very, very late at night, but then going out. And in Alabama, it was still hot and steamy, so you could drop into a swimming pool at 11 and then start all over again. Now, the great Eugene Blackstone was with Kirkland, as indeed was the great pediatric cardiac surgeon Pacifico. Nick Chukas on aortic surgery. So again, I operated, but my research project was on the damaging effects of cardiopulmonary bypass. And we found a new assay at the Scripps Institute in California for measuring complement and aflatoxins. I did that with blood from the patients in the operating room, and we showed that cardiopulmonary bypass activated complement, and that was the root cause of the post-perfusion syndrome. That was a great discovery. I also used to break down oxygenators and test the individual materials in the oxygenator to see which material really activated complement. And it was nylon. And having identified that, Bentley, who made most of the oxygenators in those days, took nylon out, and it completely transformed the damaging effects of cardiopulmonary bypass. So that was a good start.
Good start to the career.
When I came back to the Hammersmith, we started to look for ways to attenuate the damaging effects of cardiopulmonary bypass. And Charles Wilderfer, who I consulted in Groningen, told me that aprotenin was an anti-inflammatory agent. And that's how we started putting aprotenin in the heart-lung machine, and just noticed serendipitously that it attenuated bleeding. One other thing happened in '81 when I was with Kirkland. Dr. Cooley implanted a total artificial heart. And it was in the news, it was in Life magazine, and so on and so forth. And soon afterwards, I said to Dr. Kirkland on a Friday evening, I want to go to Houston and meet Dr. Cooley. And what Dr. Kirkland said to me isn't repeatable, but I went anyway. And I flew overnight from Birmingham in Alabama to Houston, and found myself in the fantastic medical center in Houston, found the Texas Heart Institute, sat on a chair in the middle of the night and waited for Dr. Cooley to arrive in the morning. And I saw him because I recognized his picture, and I said, Dr. Cooley, I'm a young English surgeon from the Brompton. I worked with Oswald Tubbs. I know you did. I would like to see your artificial heart. And Cooley took me to his office, he gave me tea, showed me the artificial heart, showed me around the Texas Heart Institute, and then I had a career-long association with him. But the very same weekend, I went up the road and met Michael DeBakey too. And that was pivotal, formative. And the next step was back in England. I went to Harefield Hospital when it was rife with transplantation, and I didn't enjoy it at all. Okay. There were 300 transplants a year virtually at Harefield. And the logistics of flying around in the middle of the night and organizing these transplants, looking after them, it was not something that I particularly enjoyed. So I started to get more and more interested in artificial hearts. One other thing I did as a thoracic surgical registrar there, we had a patient flown in from Saudi Arabia with severe burns to his windpipe. Okay. And I designed a tracheal and bronchial stent for him, never believing it would work, but it did, and the bosses let me implant it, and it became known as the Westaby tube, even in America. So another pivotal moment. I should let you get a word in edgeways.
It's fascinating to hear everything, and to such an amazing experience that you've had over so many years, and from so many different arenas as well, bringing in the States back to the UK. Moving maybe on to some of your work in the UK and talking about artificial hearts, maybe you could tell us about what happened in 2000 and your first implantation.
Yeah, I went to Oxford as a consultant, as most people know, and there was nothing in Oxford. So I had to start from scratch, and I imported surgical care assistants and started that program. And I had no intensive care beds, so we had to start fast track. And between going to Oxford and 10 years later, we went from less than 100 cases a year to 1,600 with some good colleagues. And I started pediatric cardiac surgery as well. So we developed a very exciting program, but I wanted something extra. And I serendipitously, in 1995, went to the STS meeting in San Antonio and was asked by a company to look at something that the famous artificial heart engineer Rob Javac had designed. And it was a product for perfusing the leg, as a matter of fact. But when that was finished with and everybody had gone away, Rob Javac said to me, come up to my hotel room, I've got something interesting to show you. Now, from another man, that's always a little bit worrying, but I went up to his room and he opened a briefcase and showed me a thumb-sized titanium pump. And inside that was an impeller that spins around at 12,000 RPM. And he put it in a bowl of water and it pumped magnificently. And I remember saying to him, that's a great pump for water, but it'll hemolyze blood. It's like an egg whisk. I thought, this is inconceivable. But I told him I'd like to work with him, actually pretending that I'd got an animal lab and great facilities in Oxford. We had nothing. And he said, yeah, the only other person working with it is Bud Frazier at the Texas Heart. And I said, that's great. And Javac said, Bud is here in San Antonio. Would you like to meet him? I met Bud. I went back to Houston the following day to see the calves with the Javac 2000. And then I took off back to Oxford and frenetically tried to raise $2 million to set up an animal facility in my hospital. And we succeeded with that. Frankie Vaughan, the singer, I'd operated on him twice. And he got the Variety Club to provide charitable money. And we set up a program, and Javac used to come across, and we implanted the Javac 2000 in around 30 sheep. And one of the most important things there was we demonstrated that large mammals did not need pulse pressure in the circulation. So you could have miniaturized pumps. At the time, most people believed you needed the big empty and fill, replicate the native left ventricle pumps. And it was that, I think, single point that we demonstrated that organ function was not disturbed by just having continuous flow that allowed the miniaturization and the emergence of Thoratex pump, Heartware's pump, and so on. While I was doing the laboratory work, the Houston team decided that the large HeartMate pulsatile device was suitable for permanent treatment, for destination therapy. This was the new concept. But they couldn't implant it in the States. So Bud Frazier asked me whether I could start a program in Oxford. And we did, again with charitable money. And we did quite well with the pulsatile pumps. And what we recognized in the patients with dilated cardiomyopathy was that their own hearts started to get better. So we got a clue to the so-called bridge to recovery phenomenon. And that was very exciting. And then Richard Clark, the chief of cardiac surgery from NIH, came to work with me for a year in Oxford and brought a pump called the Tandem Heart. It was the AB-180 in those days. They'd tried it 3 times in Pittsburgh without a survivor. And within 2 weeks of him arriving, a 20-year-old student came in with severe viral myocarditis. And cut a long story short, I implanted the Tandem Heart in the middle of the night and bridged her to recovery. So that was actually the UK's first bridge to recovery in viral myocarditis in 1996. Now, when I came out the operating theatre in the morning, having done that, the girl was in reasonable condition, and we were all very pleased. But the hospital medical director wasn't very pleased and sent for me and said, if you ever do anything like that again with a non-regulated device, we'll sack you. 2 weeks later, in the pediatric intensive care unit, was a young lad who the pediatric cardiologist thought had the same. The AB-180 was too big. So I called my good old friend Roland Hetzer in Berlin and said, Roland, I hear you've got an external pulsatile pump that you can use for children. And he flew a Berlin Heart across to Oxford with one of the technicians and a surgeon. And again in the middle of the night, we implanted a Berlin Heart into the young boy, irrespective of the threats to sack me, because I wasn't going to have any of that. And we saved the boy as well. He was dying of cardiogenic shock. But I biopsied his heart, and it wasn't myocarditis. It was burnt out idiopathic dilated cardiomyopathy at the age of 12. So we transplanted him in Oxford, the one and only transplant in Oxford. As you can see, I was very bad. As Bentall had said many years before, I was completely undisciplined. But you needed to be that way to push cardiac surgery forward. And that was a very exciting time. And in 2000, having collected enough data to justify using a continuous flow pump for the first time, we did a bridge to transplant in Houston. Dr. Cooley, myself, Bud Frazier, Rob Javac. That was the epic first implant of a continuous flow pump. And they said, we can't do destination therapy. You do it in Oxford. So a few weeks later, we did the famous Peter Houghton operation with the Javac 2000. And Peter survived for 7.5 years. And he became the poster boy for destination therapy. Again, very exciting. With his artificial heart, he used to travel to the States, talk to the FDA, and persuaded them that continuous flow devices were reasonable. But he was the proof of the pudding. So we had a great start with mechanical circulatory support, and then the charitable money ran out. Yeah. We had some notable successes with the Leavitt Ronix system, very, very good system, extraordinary patients. One patient who was a soldier came up from the south of England with a history of hypertension, but in cardiogenic shock, dying on a balloon pump. And I tried to work out if that was his only history, what could be going on: hypertension, heart failure, penny-dropped pheochromocytoma. So we took him from a Sea King helicopter directly to the CT scanner. He had a pheo, so I put him on cardiopulmonary bypass straight away because he was about to die. And we took out the pheo on bypass, and we couldn't get him off bypass, which I knew when I started. So we put a Leavitt Ronix in him and bridged him to recovery over a week. So that was another rare condition that we could show would recover early with mechanical support. But when the money did run out, I kept getting sent patients, a lot of them very young, and they just died. And we tried to get ECMO in time from various other hospitals and so on and so forth, but then we started having a lot of deaths. And I feel very, very strongly that every cardiac center should have the ability to rescue. You simply cannot do cardiac surgery without having the equipment to tide patients over for a few days or a couple of weeks or even a couple of months. And I think that's very bad in the UK, that all hospitals can't have rescue equipment. We lose a lot of patients unnecessarily. So I guess the last pivotal moment in 2005, when Peter Houghton was in his heyday and everybody knew about him and his artificial heart, the Prime Minister at the time gave us a reception in Downing Street. And Peter said then, look, you can't use these pumps in the UK because of the expense. You better put together a company in the UK to make an artificial heart. And actually that's precisely what we did. And Oxford had no interest whatever, so they were only interested in molecules. They even closed down our large animal lab for more space for rats, which was regrettable. So we set up a small bioengineering department in the University of Swansea, which emerged into Kalan Cardiotechnology, and we now have a really splendid British left ventricular assist device, which I think is beginning to attract attention. Thanks to a motorcar engineer by the name of Graham Foster, and my colleague in Swansea who runs the Institute of Life Sciences by the name of Mark Clement. We put the company together and it's made good progress, and that's very exciting now. That kind of brings me to where we are now and what I'm interested in doing in the last couple of years of career one has when you get to your mid-60s. I think what a lot of people understand now is I'm dedicated to showing that destination therapy is not just there as an alternative to cardiac transplantation. It's there as an alternative to palliative care for patients with severe heart failure. In the UK and many, many other countries that do not have affluent healthcare systems, if you have severe heart failure and you're over 60, you get palliative care and an early death. In the States right now, patients in their 80s and 90s are getting VADs with much better quality of life and added life years. And I think that's where the VAD story is going. Not as an alternative to transplantation, but as an alternative to a miserable death. So I hope we're going to achieve something there. And of course, the last thing is we've got to make cardiac surgery a much happier profession than it is right now. I think the scrutiny on cardiac surgeons and the focus on outcomes instead of innovation is damaging in a way. My whole career was about innovation, and that's what made it an exciting career. If your career in cardiac surgery is focused on getting the best outcomes at the expense of operating on the sickest patients, that is never going to be an exciting career. So I think that's something that needs discussing in a wider field and probably in the UK revising. So life will be a lot more tolerable for people like yourself.
Absolutely. Well, I mean, there's really not much more I can say. We've heard about so many innovations that you've contributed to over the years, so many things that a lot of people won't even know that you were fundamental in changing our day-to-day clinical practice. So thank you for everything that you've put in throughout your career and for changing the specialty as it is today.
Cardiac surgery is wonderful. Cardiac surgery transforms lives in everything from premature babies to the very elderly. So let's try and enjoy it a lot more and be less stressed and keep the patients in mind and not start worrying about ourselves. Thank you very much.
Thank you very much.